mic'd up? Okay, good. Okay, good afternoon and welcome to the DCRI Research Conference. I'm pleased to introduce today's speaker, Amy Abernethy. And I'll preface it by saying that our prior two speakers have mentioned your name probably a dozen times. It just so happens one was Rob Califf and the other was Victor Zhao. So that sets the stage for incredibly high expectations, and the bar is amazing. But I'm sure there's reason for that. Amy did her undergraduate work at Penn and then came to Duke for medical school and stayed on to do internship and residency training, and then took a 4-year hiatus to travel to Australia, where she performed her PhD in evidence-based practice and in palliative care, and then came back to Duke University Medical Center, where she's here, and it's fortunate for us. She's the director of the Center for Learning Healthcare in the Duke Clinical Research Institute, and also directs the Duke Cancer Care Research Program as a part of the Healthcare Learning Center. So today she's going to talk with us about the DCRI's newest research program, the Center for Learning Health Care, who we are, what we do.
Thanks, you. Amy. So I'm honored to be here today. This is pretty fun for me, I gotta say. And what I'd like to do is talk to you about the Center for Learning Healthcare and give you a flavor for what we do, but also invite you to be a part of the story as it evolves. There is an evolving conversation, in fact, going on all across the United States. Sometimes we're talking about personalized medicine, or we're talking about patient-centered care, which I would call the patient perspective or the individual perspective of learning healthcare. Sometimes we're talking about comparative effectiveness research, which is the comparison of interventions to try and figure out right intervention to the right patient at the right time. Other times we're talking about healthcare quality and healthcare optimization or care redesign, which is another flavor of trying to optimize healthcare and continuous learning cycles. So for example, plan, do, study, act cycles, and the idea of continuous quality improvement. Frankly, when you get under the hood, they're all different flavors of the same thing, which is the use of data to inform what we do and to continuously drive the process of care. And so, in fact, as we've started to look at the capabilities of what real-time data and data that are available to us to use today and then bank for the future sets the stage for us to do, what we've started to realize is a conversation that the United States is now starting to become being named learning healthcare. In 2007, the Institute of Medicine basically published the pinnacle workbook of the series on evidence-based practice, and that was called Preparing for the Learning Healthcare System. And this was a set of guidances about what it would take in order to have a learning healthcare system, and specifically explained that what we needed was the ability to have data available to us as well as banked for future use, clinicians and researchers who were familiar with the data and how to use it, the technology available to us, and then the processes in place to allow us to link up clinical practice and research. And so as we think about the various definitions of learning healthcare that are kind of floating around in the sea of the United States right now, I wrote them down as I was listening to a meeting one day, and here's what I heard people talking about. Learning healthcare is a process of systematically linked information for evidence generation and implementation. So systematic evidence development and implementation, and I kind of call this the research and clinical trials viewpoint of what learning healthcare is. Another is it's a national system of linked data to generate novel insights and monitoring. And I kind of imagine that this is the point of view of a learning healthcare system that comes from people who often think in the electronic health record space or the Office of the National Coordinator. It's continuously aggregating data sets to support point-of-care clinical decision-making, personalized medicine, and research. The availability of, for example, mobile apps that help us make better clinical decisions. It's closer approximation of research and practice so that each informs each other. So it's recognizing that in order to accelerate, we need to get research closer to clinical practice, and clinical practice needs to inform the research that we're doing. It's learning laboratories of healthcare to optimize and prioritize innovations and solutions. And then finally, it's an organization that learns quality and performance improvement. So this is often the organizational view, a learning organization. And fundamental to all of these is the concept of continuously available data. So this is really my kind of data slide of how this all starts to come together. And Jeff Ginsburg calls this, we sort of call it the ugly slide, and it sort of has always maintained that name, but it points out a number of things. And so first of all, it points out that we have a number of mechanisms through which data comes in: electronic health records and data collection solutions, health informatics, health IT, and cyber infrastructure, and that as these become more and more sophisticated, data are standardized, they're available, and they become a part of a continuously aggregating data set. And as that continuously aggregating data set is available, it helps to support learning processes, predominantly because we've got better analytics and sense-making that then support our clinical decision-making solutions, support our interactions with patients, such as through better education, as well as then port data over to our discovery sciences and clinical trials. So this is kind of all the big picture, what everybody's been talking about in learning healthcare and what it is. And when we started the Center for Learning Healthcare, we had this kind of vision about what learning healthcare at Duke might be, which was the foundational sort of letter of intent. This is what we were trying to do. We were trying to get to more efficient whole person care where we could think about how to better deliver the right intervention to the right patient at the right time, regardless of where the person was in the healthcare journey. Whether this person was healthy and trying to stay healthy, whether this person was a person with advanced life-limiting illness. That we wanted to achieve a vision of systematic evidence development implementation that was enabled through informatics, process, research, but also focused on a person, and that we wanted to develop better solutions to approximate clinical practice and research. So far everything I've talked to you is fairly pie in the sky. And in fact, when I first started thinking about this, it sort of, to me, was the blinking lights view of the world. You can kind of imagine that somebody was coming along and throwing a big blanket of blinking lights across the United States, which was the data, and we were going to try and make sense of it all, and boom, great things were going to happen. So as we started to talk about developing the Center for Learning Healthcare, really what we said was the Center for Learning Healthcare has to be a practical space where we start to unearth, practice, get our heads around what learning healthcare means and what it might look like. Essentially, this is a place that promotes the process of understanding what learning healthcare is and developing the solutions that we need to make learning healthcare happen. So how might you do that? We borrowed a concept really from systems engineering and software engineering around use cases, pilot projects, demonstration models. The idea that when you're actually doing a project, you not only are accomplishing the task of the project, but you're also trying to figure out what were the fundamental solutions that you need to do this particular project, and that what can you use for the future. And so in fact, what the Center for Learning Healthcare does is use a series of use cases, pilots or demonstrations, where each particular use case, the goal of the use case is to both figure out what learning healthcare is and also solve a particular problem at the same time. So essentially this is about practical evidence development and also practical solution development simultaneously. So what I'm going to do now is take that vision and that model and show you a couple of examples of what we've been working on. And here's 3 examples of Center for Learning Healthcare projects that ultimately come together to do both of those things that we've just talked about. Developing the solutions to make learning healthcare happen, in other words, starting to look at what it might look like, as well as solving one particular problem. So the first we're going to talk about is that of systematic evidence development and implementation. And we're going to focus on an area that's really emerging in the United States called palliative care. So this is the care of people with advanced life-limiting or serious illness, often both complex in the state and the issue around the illness itself, as well as complex in how it impacts people's lives, the patient and the family. So it's inherently patient-centric, and it's also inherently complex. And one of the interesting things about palliative care in the United States and actually internationally is that it's an area of huge, it's kind of like the great desert in terms of available evidence to currently guide practice. So we need information for just about everything. And also there really wasn't a lot of coordinated systems to allow us to think about evidence development and implementation. And so in fact what we wanted to do was develop up in a new age kind of way a mechanism for systematically figuring out what questions we needed to answer, getting them answered, and then getting the answer into the clinical space, watching what happened and figure out what the next question is. And so what ends up happening is that we start to continuously monitor what happens in real time at the point of care in clinical practice, as I'll show you. Use that information to prioritize the clinical questions that need to be answered. So essentially use clinical practice to tell us what research needs to be done. Then have a mechanism to quickly port that over to clinical trials. Develop the mechanisms for efficient evidence dissemination, including the metrics that tell us how things are being implemented in the practice, and then also in a coordinated fashion start to educate the workforce. Now, you kind of say to yourself, well, that's what the DCRI has been doing all along. And in fact, I would submit to you this is a micro model of what the DCRI indeed has been doing all along. And really the fundamental difference is that this time the entire system is being organized with the same data flowing through all the way. So for example, the measurement of pain being conducted by exactly the same measurement instruments, so 0 to 10 scales where everybody understands the anchors, that the information systems are all connected up and flowing, and that as information flows from one point to the next, it can do so efficiently. So the first thing that we did was, with funding from the Duke Endowment, Robert Wood Johnson, and then also private organizations, developed something called QOACT. And I'll show you a little bit more about QOACT in a second. But QOACT is the quality data collection tool. Really a fancy name. I don't think so. But basically the idea was we need to be able to support continuous quality monitoring, because by supporting continuous quality monitoring in the context of clinical practice, we'd be able to understand what clinicians were doing on the ground. So QOACT is essentially a point-of-care quality monitoring tool where physicians and nurses, whether they're in nursing homes or patients' homes or in the hospital or in the clinic, can enter the information that allows them to understand how they're doing in terms of meeting current quality guidelines in the context of providing palliative care. That same system also provides the information that flows into a registry. So the point of care information is designed such that it's populating a registry that's growing right now across a number of practices in the state of North Carolina, and actually by the summer will be in a number of practices across the United States. That registry is being funded by a number of sources, the NIH, ARC, and others, and is essentially a growing data resource where we're starting to understand what does care really look like at a national level. So not just quality monitoring for this particular physician or this particular practice, but across the entire group of practices, what does care look like and where are gaps in care? That system handshakes then with a clinical trials group. So we intentionally developed a clinical trials group where the data that the clinical trials organization is using is exactly the same as being used in the quality monitoring system. And so essentially the questions that the clinical trials organization is starting to answer are in fact directly relevant to what the registry system is telling us need to be answered. And so the way this particular cooperative group is organized is this cooperative group is responsive to what clinical practitioners are saying, this is what I need to know. And then we're partnered not only with the clinicians in practice and the cooperative group, but also the peak professional bodies. So for example, with DCRI, you're often partnered with the cardiology peak professional bodies. So here with the palliative care peak professional bodies, as well as all of the major journals, so that as information comes out of the clinical trials group, it directly then goes into the educational programs for workforce development. Our PC Facts, which is something we also developed, which is essentially the journal watch for palliative care, so quick dissemination program across the United States, as well as we also have directly relevant to this entire cycle, our own section in the major journal for palliative care. So ready as the information comes out to go into a real-time section in the journal. Again, fairly pie in the sky, let's drill down further. So I've kind of told you in the beginning that data and technology are part of the unique feature. It's sort of that innovation piece that's really made a big difference in allowing us to do it all. So now let's talk a little more under the hood about the data and technology piece. So this now is some of the information around QOACT. And you see here Arif Kamal, who is the junior investigator who's been responsible for developing up this work. He's over here in the right-hand corner. This is actually the DCRI's video solutions, and so we were able to tape videos that we have all the way through the QOACT system to tell clinicians how to use it. And importantly, what we did with QOACT was we partnered with the community clinicians. Every 2 weeks they get on the phone, and during that phone call we do two things simultaneously. So the reason that they get on the phone is it's the opportunity to share best practices, talking with other doctors around the state. How do you do it? What do you do? How do you make sure your practice is being done well? The other half of the conversation is help us develop the software we need to develop for you to be able to make your practice better. So we make sure that we are combining those two things so people get on the phone, and then we also get our software developed at the same time. And what they told us was, if we're going to do point of care clinical monitoring, if you're going to get us to put data into these systems, we need the systems to be simple and efficient. And so we worked with them to develop a number of software solutions that met their needs and that they were continuously telling us this is what it should look like. And so in this particular case, this is QOACT. And what you can see here is they told us we need a patient census that looks like this. It's actually not projecting very well, and if we get time in the end, I can actually show you in real time what some of these things look like. One of the things that we realized was that the user interface is critical. If it's ugly, nobody wants to use it. If you can't find where the buttons are, then you just quit. And so, for example, Laura Rowe, who's in the room, is a graphics designer, and so we make sure we include graphics design early in the process, because making sure clinicians want to use it is a critical feature. We do formal usability and feasibility testing under clinical trials protocols to make sure we understand, is the system usable and feasible within the context of clinical practice. And so Cheryl Brewer in the room leads a clinical trials team that includes within their capabilities the ability to do in-clinic usability and feasibility testing. The clinicians told us, we need to make sure it interacts with the local electronic health records and administrative databases. So for example, right now, the system pulls in administrative data from the local administrative systems, and we interact now with 2 different electronic health records, and the number of electronic health records with which we're interacting is increasing quickly. We just now put the system into Epic. Meanwhile, the system then ports into a series of questions. Each of those questions align directly with the national quality metrics. We did a systematic review that's currently been submitted for publication. There are 283 quality metrics for palliative care in the United States. If you can possibly imagine, to me that's kind of a ridiculous concept to begin with. 283 things that a clinician must meet in order to be providing the highest quality care. And so we made sure that every single one of these could be reinforced within QOACT if the clinicians nominated those are the metrics that they wanted to be following. And one of the things they told us was, tell us quickly whether or not we're doing a good job. And so as you see here, there's a red bar. That red bar says this metric's not being met. In this particular example, it's whether or not we have adequate mechanisms for communication for a person who has delirium, so the color changes in real time to flag. You need to do something different here. And the clinicians also told us, listen, it needs to be quick to navigate through, and it needs to work with the way I work in clinical practice. And so one of the things over time we designed was this navigation schema. Importantly, don't worry about, oh, I don't like that navigation schema, or I don't like a different one. The point here is that the clinician said this is what I need, and we're able to develop it very, very quickly in order to make sure we've got usable systems. Meanwhile, kind of back at the home office, so to speak, Joe Kelly and team, Ursula's here, and the newest member of our team, James, has just joined us today. We have individuals who are helping to work on developing real-time reports, for example, that then can be sent over to the clinicians who are using the system. And here Arif's getting some big checks for how well he's managing some of the problems in the palliative care setting. And meanwhile, the clinical trials testing team is doing a series of human factors research studies to make sure that we are optimizing the system as well as possible. And these studies are done in IRB-approved protocols so that we can make sure that we are not only managing patient protected health information well, and we're doing so within the context of best science, but we can publish results in the end if we need. Now, in order to pull this off, you got to imagine that it takes a lot of people working together. And so we need data architects and data analysts, software engineers and graphics designs folks, but we also need the important input of statisticians, and so Greg Samps is a lead statistician in the center. Clinicians, so Arif Kamal as a palliative care doctor and oncologist is critical to making this project work with the whole IT team. And we need folks who understand clinical trials, because remember, the whole system is supposed to port into the clinical trials organization next. And if we're not ready for how the data needs to flow into the clinical trials organization, we're not going to be able to pull it off. And so importantly, one of the things that I think the Center for Learning Healthcare is about is how do you pull together all of the people who need to be at the table having the conversation in order to make sure that you develop the best solutions. Two groups of people we haven't really pulled in yet, but Brad Hirsch is working on, because this is what you know is the critical next step, are infographics and visualization. And so those two types of team members will be at the table very soon. And right now we can kind of sub it out, so to speak. So what happens? Well, interestingly, the system has been so efficient that many people can't really tell that this has been the underpinning for the cooperative group. But in fact, the cooperative group, the Palliative Care Research Cooperative Group, was something that was a part of the overall vision to begin with. We didn't just say, gosh, wouldn't that be nice to have a cooperative group? We actually said, you know what? We're realizing that if we're doing quality monitoring in practice, we have no way of doing the clinical trials once we learn that there's a problem. So we actually need to create the organization to do those clinical trials. And what if we create the organization to be as efficient as the quality monitoring program? And so in fact, developed the Palliative Care Research Cooperative Group. It was funded by the NIH 2 years ago. And one of the reasons I show this is that we're really proud to say that it was the first 2 years were so efficient, and we made such progress, including our progress in technology and data harmonization, that there was a limited competition for the next 5 years for the cooperative group with $10 million of funding, recognizing that this system is directly responsive to the other system, and those two things handshake together. And so if you put it all together, how do you now make a learning system where you've got technology, you've got clinical trials capabilities, you've got clinicians who care and want to be a part, you've got the idea of creating quality metrics, and here's what it might look like if you put it all together. So in 2005, we published in the British Medical Journal that, hey, you know, it's kind of fascinating that for people with advanced life-limiting illness, we have no clue how to take care of their comorbidities. How do you manage hypertension in a person who's dying? What do you do with their statins? What do you do with the management of their diabetes or their osteoporosis? Do you keep them on all their drugs? One of the interesting things we published right around that time was that the number of medicines that people were on were rapidly escalating in the last year of life, because you can imagine you start getting pills for the management of your pain and constipation. At the same time, you're taking all of those pills for the management of your heart failure and diabetes, plus your cancer and your osteoporosis. So how do we start getting rid of some in a thoughtful way? We then did a national survey of clinicians across the country in the palliative care setting and said, hey, how do you manage the medications for comorbidities in the palliative care setting? Remember, we're partnered with the national or peak professional body, so they helped to distribute a survey for us. Clinicians from all across the country said, here's what I do. And in fact, what we learned was that the management of statins was a place of complete equipoise. Half of palliative care doctors discontinue statins in the last year of life, and half continue them. And it's not related to whether or not this person had underlying heart disease. It's not related to whether or not the clinician was in an academic setting. It was most related to whether or not they'd had the opportunity to talk to the primary care doctor. So we actually didn't know what to do for the management of statins. So the cooperative group is now poised and ready directly for learning how to better manage statins, and so now opens up a randomized controlled trial of continuing versus discontinuing statins in the setting of advanced life-limiting illness. The trial results are already paired with PC Facts in the Journal for Pain and Symptom Management, as well as thinking about other communication mechanisms, including other journals. But we're already ready to go as soon as the results of that trial come out. The trial will be done this summer, and these organizations are already aware of and you need to know about as the trial results come out. Meanwhile, we've already been thinking about what would be the metrics to monitor management of medications in the outpatient setting within the QOACT system, and included within that to monitor how those clinicians are managing statins. So then the quality monitoring system can do two things for us at the same time. Monitor how clinicians are uptaking new evidence, as well as provide real-time feedback in terms of best quality care. And we can use that system then to figure out how do we better need to teach and educate the workforce if appropriate, and also then use the same overlying system to crowdsource the next clinical question. And Zubin knows that one of the things I keep talking to him about is one of our critical questions of how do we essentially crowdsource the clinical questions directly from doctors, patients, payers, and policymakers so that the entire system is responsive to the users of the evidence, essentially. So kind of that's on the big scale of what we would call systematic evidence development and implementation. And as I leave that one, I want to leave you with a couple of things that I think are sort of fundamental to how we're thinking about this. One was that we need to develop the technology when the technology solutions are missing. I don't think the Center for Learning Healthcare is a technology development shop per se, but certainly that's one of our core competencies. Again, not because we're a software development team all the time, but because software development is critical to filling in the gaps. And therefore, when you find that you have a gap and technology development would help you, we're very excited about the opportunity to work together with you, and I can show you some more examples. The second thing about this overall system that's kind of a core competency for the center, and Tracy Locklear is in the room, and maybe this is actually also starting for her to help her see how all these pieces that she's been working on fit together, is that we're always thinking about how do we measure the same thing in exactly the same way all the way across the system so that we can pull the data sets together now and in the future. And the third part of the core competencies is that we do have to think about subject matter expertise. If we don't have the subject matter expertise within the Center for Learning Healthcare, where are our partners so that we can make sure that we've got it? And so, for example, community-based palliative care, we're not community-based palliative care people. A lot of this has got to do with the community. So we needed to make sure we partnered with community-based palliative care practitioners across the entire state to make sure we brought together their subject matter expertise and their needs in order to make the whole system work. So the second example that I'd like to talk to you about is sort of a learning laboratory example. This is the mobile health approach to efficient patient-reported outcomes collection. I think that one of the things that I'm proud of, probably the most proud of, besides the people in the center, is that the center's inherent focus on people as patients and patients as people. And this idea that one of the things that we've always got to do is develop systems and solutions that are meant to enhance the care of real people. And so patient-reported outcomes, therefore, become fundamental. It's not like our fundamental data set, and everything else leads out from there. And so as a result, one of our core competencies in is patient-reported outcomes. And you've already heard that technology development is a core competency. And so ultimately, if you put together patient-reported outcomes, so things like symptoms and quality of life, plus technology development, what ends up happening is that we have a great and unique environment for continuous patient-reported outcomes implementation, solution development, and thinking about what that looks like. Over time, what we've learned is that in order to develop patient-reported outcomes data collection solutions, it's 4 pieces put together, each of which is interchangeable. So sometimes people will say Amy and her e-tablets. It's not really Amy and her e-tablets. E-tablets were just a piece of it. A lot of the times when people will say Amy and the PCM, which is a patient care monitor, which is a kind of patient-reported outcomes instrument. PCM is just one choice of instruments. And so what we've learned is that it's the combination of the data collection solution, so the software and hardware, plus the instruments that we've chosen. So any particular survey instrument for any particular point in time or clinical solution, plus how it's all been put together in process, as well as the reporting and analytic solutions put together that are ultimately all needed in order to create one complete learning system. And I'll tell you that what we've also learned is that the secret sauce isn't software, and it isn't instruments, and it isn't even reporting and analytics. It's process. In fact, it was going back and learning from those community practitioners on those phone calls every 2 weeks. What do you need and how do we make sure that this works? That's what make QOACT really work. And so as I'll show you, it's putting all of these pieces together. So, for example, as we think about the process, a patient might come into clinic and report information using some kind of technology. Information that says, here's what worries me, here are my symptoms, this is my quality of life, these are the medicines I've taken. The kind of software and hardware you choose doesn't really matter. Ideally, we've created solutions that are fast and efficient, that don't cost a lot of money, and that have the look and feel that attract people and that they want to use them. But it's actually really hardware and software agnostic. So in fact, these are the old e-tablets that we used to use, and I used to have a joke that I'd buy them on eBay, because eBay was where I could get the old cheap ones that had been sitting in a warehouse somewhere. It just doesn't matter. It doesn't have to be the coolest technology. We've had a long time and a lot of experience using digital pens, which work well for certain scenarios, because some people don't quite know what to do with a computer, but they can understand what to do with a pen. iPhones and mobile solutions have certainly become more and more part of our landscape, and a lot of the things that we do right now are gauged for iPads and other similar devices. And certainly, your laptop and your desktop all work just as well. And one of the things that makes me laugh, because I came to the DCRI and I got a copy of the slide deck from Tom Kaminsky, and if you look up there in the corner, you see our e-tablets. So these are the e-tablets that were running in the Duke Cancer Center from about 2007 to 2011. I always think it's kind of funny that they're up there in the corner. And if you go back to that little bitty picture up in the corner, you see that there's a green survey picture. And that green survey picture in its current updated framework looks like this. And so this is an example of the kind of patient-reported outcomes survey questions we might ask a patient. And so one of the things that we've learned over time is that one of the efficient survey instruments for us to choose is something called the patient care monitor. You see that up there in the... And we've learned that, by the way, you should only ask, when you're asking patients, you should only ask one question per screen. The screens should change very, very quickly so that there's no delay or lag time. The machine needs to work even if the person gets in the elevator. We've learned all kinds of funny things like that. The color of the buttons, the size of the buttons, all from the usability and feasibility testing. We've published pretty extensively on what keep patients using systems. So patients tell us, listen, I'll come to clinic and answer as many questions as you want me to answer, provided you do the following things. Two things. One is educate me at the same time. So one of the things that we've learned is that if the patient comes into clinic and they tell us that their problem is insomnia or they're having problems with sleep, don't teach them about constipation. Teach them about better management of sleep and the things that they can do for their management of sleep. So we need to match those two things together. The other thing that patients told us is, I'll answer all the questions you want, but you need to make sure that my physicians get the information. The physician there being kind of a broad name for the entire medical team, so it can be the nurse, the physician, the nurse practitioner, the social worker, but somebody needs to acknowledge that I've done this and make sure that it reinforces in the system. And so one of the other things that we've learned then is that you have to have systems in place also that allow physicians and nurses and healthcare providers to do this quickly. So in the patient care monitor, which is one of the survey instruments that we use, but Susan Locke, who's here with us, can tell you that we have a whole long list, and it's always kind of one of the challenges is deciding which survey instrument for which problem. So with the patient care monitor, it's 80 items. So let me kind of explain this to you. The oncology patient comes in, he or she sits down in the waiting room, starts answering a series of questions. 80 items, that's a lot of questions. And every time we try and get rid of some, we realize that the oncologist really needs all of that information to be able to do a complete clinical review of systems. So as we've tried to get rid of things, then the oncologist says, but wait. So we realized we had to do all 80. But it's really hard to read through 80 items. Just think about reading through 80 lab tests and trying to go all the way through. So you need to create then efficient ways for the oncologists and the nurses in the clinic to know what the information means. And here, what you see is a color-coded report where the colors, whatever's in orange, tells you those are the places to focus your attention. And what we've learned is that oncologists are very good at identifying specific patterns and learning patterns quickly. And so that, one of the things that happened as I was sort of studying this, I was fascinated by it because one time a report came up, there was a lot of orange. I was watching the oncologist in the clinic. I said, wait, there's a lot of orange. Don't you be worried that that patient is distressed and there's lots of difficult things going on? And he said, no, that's a standard day 10 after chemotherapy pattern. I will be worried if that pattern doesn't resolve or if the person didn't have that pattern after receiving chemotherapy. So the pattern itself was very important in a way for the clinician to know. And so what we've learned is that not only do you have to have solutions that meet the patient's needs, this is a part of process, you have to have solutions that meet the physician's needs and the nurse's needs in a way that they expect them. And you have to be able to change those solutions quickly if they're not meeting people's needs or if they tell you, and in addition, I need. And so, for example, with this report, the GYN oncologists actually needed a special set of figures and information down here in the bottom right-hand corner that was relevant to GYN oncology, and so we needed to make sure that they had the GYN. So what happens is the patients answer questions, and they could do this at home or they could do it on their iPhone by the physician and the nurses for review of systems and clinical decision making. It triggers patient education and it triggers other interventions. So we start to embed it and bake it into the process. And so here's an example of how it starts to trigger interventions, and this is a distress triaging process that we piloted in the lung cancer clinic, and is soon to be tested in Susan at Rush, right? Like that's where we're about to do this. So in this particular example, patients come into the clinic. This is thoracic oncology, so they come into one of our clinics and they answer questions. The questions then go into the report. That report has a series of pre-calculated algorithms that help us know against a population-based norm what is an increased level of distress for a population of cancer patients. If the patient has too much distress against that population-based norm, a message is automatically sent to the social worker or psychosocial care provider in the clinic based on what that clinic's normal triage process is, while the patient's still going ahead and getting their usual care. And then by the time the patient finishes seeing the doctor or nurse, the psychosocial care provider is there and ready to see the patient at the time. Nobody has to get on the phone and make an additional phone call. So the idea becomes you can start to embed the process, embed the flow of information directly within the process of care. And in fact, the other part of that then becomes that you start to study what all of this demonstrates. So for example, the automatic triage, what happens to distress for this particular patient over time, and continuously optimize the overall process. So right now, for example, in the old-fashioned version of this, it was a distress score of 65 automatically got you a phone call to the psychosocial care provider. But we've started to learn that 65 is not quite the right threshold for everybody, and here's how we optimize that. So then once we have the data, we can use it in all kinds of ways. We can port it over for research, as well as we can start to develop clinical decision support and guidelines. And importantly, one of the other things that we need to remember is that the symptom data and the quality data is only one part of the data story around any one particular patient. And so, for example, we very intentionally put these data sets within the decision support repository, Duke's Enterprise Data Warehouse, so that these data sets are inherently linked to clinical and administrative data, We've also linked them, for example, to clinical trials data as well as biospecimen data together with Jeff Ginsburg, so that through a series of coordinated databases, we've got not just patient-reported outcomes information about a particular patient, but we've got patient-reported outcomes information combined with their clinical and laboratory information, combined with what happens for them within the context of a clinical trial. So then, the learning laboratory environment allows us to do multiple things simultaneously because of that progressively more sophisticated data. So first, it allows us to think about how to optimize care for this individual person. So right now, what are the reporting features and what are the triage processes we need to optimize care for Charlie or Susie? Also, we can start to do care redesign and improve clinical operations. So this is actually a true example. Bill Fulkerson in a meeting said to me, Amy, we're trying to figure out whether or not pain is a problem in the cancer patient, in the cancer clinics at Duke, and there was a whole bunch of people around the table, and everybody was kind of just talking, and I sort of stayed quiet for a few minutes, and I did a little bit of typing, and Joe Kelly was on the other end of the line, and Joe and I went back and forth. After about 15 minutes, I said, well, actually, last year, greater than 21% of the patients being seen in the Duke Cancer Clinic had a pain score of greater than or equal to 4 on 2 or more visits. And I actually was able to answer for that for Bill sitting in the middle of the meeting within about 15 minutes. So we can think about how do we do care redesign because we've got better data about what's going on. And then finally, you can imagine that there's multiple research reports and stories, and I'll just tell you one example story that's kind of come out of all of this. It's got reasons to tell you for both sides. So one example story is that we were doing all of this work, and so we realized that if we looked at all of these reports, one of the areas on the reports that routinely demonstrated high levels of patient distress, just by visual inspection, was sexual distress and sexual dysfunction. Now, I'm an oncologist, and I got to admit, like, I didn't know what to do with that. And so the first thing that happened was in the clinical operations frame, we started to just try and understand how many patients had sexual distress. It's a third of people in GI, breast, as well as prostate and lung. So almost every cancer clinic, about a third of patients had sexual distress scores of greater than or equal to 5. All right, so Krista Rowe, who I think actually walked in. So Krista and I actually tried to figure out what kind of educational pieces were down there in the clinic around sexual distress. There were sort of, you can imagine the clinical rack. Some of them were in that rack over there, some of them were in that rack over there. We tried to figure out what was in the clinic. It was kind of a little bit disorganized, but Krista got it organized, and we had the better information. We monitored to see whether or not the level of sexual distress changed. Not much happened. Went to the psychologists and went to Frank Keefe's group and said to Frank, you know, we don't really know anything about this problem, but maybe you've got people in your group who know more about it. So Frank, he nominated a woman named Jenny Reese, who's now at Hopkins, and we still work with her frequently. And so Jenny and our group wrote a series of papers, all of which were published around how frequent sexual distress was in the cancer patient setting, what it correlated with, which patients were most worried. That went on for about 9 months, and then Jenny and the psychologists developed a flexible coping model that they published. So about 10 months after the first day in melanoma clinic, when we realized this sexual distress thing was so obvious, we went to the American Cancer Society and we said, you know, we see it's a problem. We realize that nobody's actually talking about it and there are no interventions. We'd like to propose a randomized trial. And within 15 months of that first day in the melanoma clinic, when we realized there was a problem, we'd actually already had a randomized trial funded from the American Cancer Society to start to study new interventions for the management of sexual distress. And that study now is ongoing actually at Hopkins rather than at Duke, just for practical reasons at the moment. But in fact, what's happening is they're using exactly the same systems to monitor patients, identify patients who are appropriate for the intervention. If the patient is appropriate for the study and the intervention, there is an automatic signal that's sent to the research coordinator from the electronic systems. The research coordinator gets the page, goes and talks to the patient about potentially consenting to a trial. If the patient is in the trial, then the same electronic patient-reported outcome systems then monitor the impact of the intervention within the context of the patient's life. So as the last example, and this one will be quite quick, what I'd like to talk about is knowledge products as a byproduct of having these kind of unique data environments. And this is Tracy Locklear's figure down here, and she didn't even realize I was going to put it up. But the reason that this figure is so important is that it highlights the fact that intentionally every single one of the data systems that we've been designing are linked up. So across that learning laboratory environment, pain is always being measured in the same way, if at all possible. And we keep data maps that remind us how different things like pain or quality of life or cancer stage or performance status or survival is being assessed in all these different data systems so that we can understand how to line up the data very efficiently. And because of that, then we're able to do all kinds of knowledge products, or essentially activities that then relate directly to the more efficient conduct of research within the context of clinical practice. So we've got a number of real-world cancer registry models that are developing. So for example, community and academic data sets that are being put together and include patient-reported outcomes. And so Brad really leads a lot of these activities, and the idea being that we can better understand what clinical practice looks like in the real world because we're partnering our data sets with other community-based and academic settings. And we're driving that because we're making sure that continuously all of those data are standardized going in. We're able to think about things like treatment sequencing, so what order of treatments should be given, adverse events, comparative effectiveness research. And actually, the funding for these is diverse. So we're finding that lots of different companies, as well as the government, is becoming progressively more interested. Certainly, palliative care has been one of our huge use cases, but it's not just clinical trials or better quality monitoring. We're actually also starting to think about health policy development. And so probably one of our unique and unusual things we're doing within palliative care is saying, you know what, because we have the data, we can actually tell Washington, here's a better way of thinking about the Medicare hospice benefit. And so, in fact, one of our huge areas of funding in palliative care right now is RWJ and AHRQ around policy development. The third is personalized medicine, and so together with Jeff Ginsburg, we had a GO grant from the National Cancer Institute where we think about pulling all of these data sets together to become clinical annotation data sets for biospecimens. So we now have tumor tissue as well as the clinical data coming together so that we can think more carefully. And then ultimately, using the same data systems to evaluate new models of care. And Sophia Smith is leading the Pathfinders or Pillars for Life program, which is now funded by the Livestrong Foundation. And John O'Donnell has just joined us in this. And in fact, what we're doing is we've taken a pilot program that was at Duke using exactly these same data models to study Pillars for Life, and we have rolled that out across the United States to 20 sites across the country, funded by Livestrong. So, in summary, the Center for Learning Healthcare is a place that values data, innovation, and subject matter expertise, and that's what we see as the core substrate. The idea is that we're going to be using demonstration models or use cases to figure out what do you have to have in place in terms of technology and process and people in order to have learning healthcare happen. We've got internal and external mechanisms to think about implementation and implementation science. It's been really important for us to keep our clinical trials footprint called our the SBR or CRU, and that's because that is the place where we're always testing new models, whether that's new usability and feasibility testing, new clinical trial models, et cetera. So it's been really important for us to do that here at Duke, but then we also have a national footprint through which we can do it. And we're very intentionally aligned with multiple organizations across Duke. One of the things I hope that you've heard from me is that it's not just a little bit of group of us working together. It's actually all of us working together with multiple people in the Duke environment and as well as in the national environment and frankly in the international environment. In terms of our assets and our approach, we have really incredible bench strength in technology development, and I'm really proud of this. I'm really proud of everybody. And I'm really proud of the fact that we've figured out ways to develop technology when sometimes it's hard to develop technology in the Duke space. And this includes mobile health solutions, informatics, databases, and then bringing in data visualization, representation, infographics. So thinking about what do we need to make healthcare more efficient. We certainly want to bring to the DCRI our focus fundamentally on the patient and patient-reported outcomes and patient-centeredness. And I think that this is something that we hope to partner with all of you about over time. We've got growing subject matter expertise in topical areas. So certainly palliative care and cancer has been our thing for a long time, and I'd like to see us continue to grow in partnership in cardiology and GI, and also in other areas beyond the boundaries of medicine, including policy and computer science. And financially, we've been built on a model of sequential bootstrapping. Almost every project is feeding into subsequent projects, and sometimes internally that can be a little bit confusing. What project am I working on, and how does it relate to everything else? Frankly, I recognize that, but it's been quite successful for us to date. This is to remind me, if I haven't said it enough, that this is fundamental to the story. The reason that the Center for Learning Healthcare exists in an academic environment and not its own company is because, by definition, we want to think about how do we do things differently to change healthcare, and we need to be inside healthcare and thinking about doing so in a place where there's the kind of expertise that Duke's got to offer. Who are we right now? I think we're everybody, we're all of you, but there are some people who have their feet on the ground thinking about Center for Learning Healthcare every day. Greg Samsa is our lead statistician. Brad Hirsch leads our efforts in informatics and learning laboratories, and really helps to think about how we're putting all of this together in a thoughtful and sophisticated way, and how do we do so in a way that partners with investigators across the DCRI and more globally. Yusuf Safar is an oncologist and helps to think about applied health policy. Arif Kamar is an oncologist and palliative care physician who helps to think about palliative care research and quality. And Sophia Smith is a PhD social worker with an incredible background in health IT, as well as what it means to be a patient, who helps us think about both mobile health solution development as well as survivorship. And Tom LeBlanc will be joining us as another faculty member in palliative care starting in July. There's over 20 FTE staff, including informatics and health IT, quality, data analysis, reporting, clinical trials team that really is second to none, and administration. And it really is everybody working together. And I do put down here, because everybody's like, where are you? We're located in 6 buildings across the campus, and ideally we'll be co-located with DCRI at one point or another, but in the meantime, it is what it is. In terms of center matrix structure, we're organized like a matrix, so essentially we're a mini DCRI matrix within the DCRI. We have all the things that we've just mentioned: health IT, clinical trials, patient-reported outcomes, analytics, operations, business development, education as kind of core operational areas, and then the core subject matter expert areas that I've mentioned. And finally, I wanted to mention this because I think that one of the things that the Center for Healthcare intentionally doesn't do is replicate what other people are already doing exceptionally well, but rather think about where's the overlap and how can we be synergistic. And as an example of that, there's the Center for Personalized Medicine, which has been a key partner for us for a long time. And they've got genomics and discovery sciences and prediction models and translation models and personalized care interventions. And we can start to partner with them to think about personalized medicine learning laboratories, optimization of personalized healthcare models, the role of behavioral medicine within this space, and how do we develop policy for personalized medicine. Because ultimately these things are inherently overlapping. And one of the things we want to do within the Center for Learning Healthcare is not be competitive, but otherwise be thoughtful and synergistic every time we come together. So I'm going to end there and ask for questions, but if anybody ever wants to look at technology examples, we can also talk about that. So thanks.
Good. Thank you, Amy. That was fascinating, and I can see why so many have sung the praises of the group. Questions, and perhaps I'll start. When I was thinking about patient self-reporting, I was wondering how one avoids health disparities, meaning you have some individuals who are not literate. You have older patients. You have very sick patients. You have distressed family members. You have differing cultures. So I'm sure you have a plan as to how one works through that. I'm just trying to imagine some of my patients with an 80 question something on an iPad or a tablet sitting in the waiting room and getting something back that's either blank or that there's a streak through every one of the questions. So how do you address that? What is your solution?
So this is a huge issue, and there are several parts to the solution. So first of all, there we go. As I highlighted, that the choice of instrument is critical. So for example, the ESAS, which is only 12 items, is often what we'll choose for very, very sick people, as opposed to the patient care monitor. So we change up instruments frequently depending on situation. One of the reasons that you saw, for example, electronic pens is because pen and paper are what is appropriate for certain groups of people. And it's important that we mix and match technology and that we have a portfolio of technology available and instruments to meet the different kinds of needs. And in fact, one of the things that we've studied is if a person is at different levels of, in oncology we call this performance status, so for example, different degrees of heart failure, what's the technology and the question set to match how sick they are, as well as their caregiver? Because one of the things you've also said is that the information from caregivers is very, very important as well. QOACT accommodates for the fact that not all patients can answer for themselves, and so we get caregiver responses as well and physician responses for some of the same information.
Other questions? Please.
I am in the QOACT group at DCRI, and we think about quality assurance, mostly processes, and within a single department, yet alone a whole organization, we struggle with the variations on the standard processes. Now, you are talking about physicians across the nations on different database, different specialty. How do you, and I heard over and over again how you emphasize on process, which is what excites me, and how do you think about all the little variations and how they are impacting the data system? Because it's not only everybody have to work collectively, but they also have to understand how a variation can kill the final objective. So, but at the same time, they have a day-to-day needs and scenarios and exceptions they have to deal with, so it's difficult for them to stick to a standard process if we have an ideal standard process.
So what you're asking is this critical question, right? So we can develop optimal processes, and then two things happen. One, practice variation naturally happens, and then two, people just can frankly ignore it, right? So first of all, one of the things that the QOACT story has taught us is how to really, you may have a suite of standards, but there are only a few that everybody agree are core. So that we try and stay away from an expectation that everybody has to do everything except for some core activities. The second thing, and frankly, I'm about to try this out in a group of practices in Tennessee, so we'll see how this goes, is to reinforce the message that we recognize these things can be hard. So hear how we're helping you so that we're not increasing the burden. So first of all, you always have to keep things burden neutral, right? So it can't increase the burden. And ideally you start to reduce the burden. And so, for example, in oncology, one of the data points that oncologists are frequently being asked to collect is performance status. So we're trying to come up with ways to fill in that data point, because from a standardization point of view, it's critical, it has to be there. But the technology approach frequently is to say, darn it, the oncologist is just going to have to fill it in because it has to be there. But instead, can we start to figure out other ways to backfill everything that we can backfill, so that the things that people absolutely have to do are at the absolute minimum. And then the other part of that is to reinforce that message, to tell people, we've heard you, this is a pain, so here's what we're doing to try and minimize the burden. And that reinforcement of the message becomes very, very critical. I could go on and on, but I think that you sort of get my point, which is minimum and understanding the burden is pretty critical.
I think this is very impressive work, and
Thank you.
I think there are two areas that you can really contribute to that you haven't really maybe thought of as well as you might. And it kind of amazes me because you're in oncology, but it seems to me that one of the things that you haven't really talked about is the objective, first of all, of the patient, and then secondly, the treating physician. And and that is sometimes difficult to trace and track because families don't want to know that the husband's about ready to die or father and so forth. The second one, though, are decisions, medical decisions. And it is just impossible, and I think mainly for medical legal reasons, to get docs to write or to even let you know what they're thinking and what they're really trying to do. And that is the big Achilles heel of mining the data that you have now. You can say what the action was. You can't say whether the decision was right or not. And the first thing you have to do is make sure that that your decision was a good one. You really did need to have that procedure or whatever. So I'd be glad to kind of share 10 or 20 years of thinking on this topic with you at another time, but I think those are the only two areas that I'd be a little cautious about. And it's good to see your caution on the value of technology. First of all, you need to be able to handle information up with a pen and pencil and a pad, and that's it. And then you can get to very fancy technology if it really truly helps. So I think these are some of the things that have been traps in the past that you clearly avoided. But maybe you just talk a little bit about, are you trapping patient objectives for their cancer care, like beyond just pain relief? Or are you talking about, do you want to, would you rather just go out and have a cruise, or would you rather have maybe 3 extra months of life?
There are two, you've said so many phenomenal things that I'm going to respond to two specific ones. And I watched Brad turn around and look back at you, so I know what he was thinking. So one of the things about clinical notes, as you know, is that the real data is what happened in the outcomes. Everything else, history, is history, which ultimately becomes outcomes the next time you get a new clinical note. So we had, it's now finished, an SBIR kind of grant from the National Cancer Institute to develop new clinical notes that basically create structured data out of everything from the medical decision and why downward. And the reason for that was to try and reduce burden, but start to capture that kind of critical piece of why did you make this particular decision from the physician standpoint. And Dan George has been really incredibly thoughtful about how do we capture that I made this decision because. But what we've learned is we've tried to capture those data is what you were saying, which is as soon as you say to the physician, I need to know this, you got to also say, and here's how I'm taking away these other tasks from you so that you can answer this particular question right now. And so that's kind of how we've been working on it, and I don't think we've gotten it right yet. But what you're saying from the physician decision-making standpoint is critical, because the other thing that is happening there, especially in oncology, is if you're deciding to change the drug, you're doing so because you've interpreted that the drug's not working, it's too toxic for this person, or something else, and you may have clinical sensors that are providing early sensing of what's going on. And wouldn't we want to know what that correlates with if we're going to develop better prediction models and other things? And so we need to know what that physician intuition looks like right there. The other part of what you said, which is the patient's value and the patient's judgment and needs. And we've, in these examples, I really have stayed with, good old-fashioned patient-reported outcomes and stayed far away from values and the metaphysical. But in fact, I don't think, so the points of what people value most and how that informs the decisions that they make is, if anything, going to be the most important part of the information. That's the part that we can't get any other way, and in fact really should be driving what we do. Yusuf Zafar has been probably the person most thoughtful about this on a day-to-day basis within our team right now, and he published a paper together with Kevin Schulman and Kevin Weinford in support of Care Cancer about 4 years ago, sort of trying to say, you know, patients make a series of decisions over time informed by lots of personal experiences as well as information coming in from other people, and how do we think about those decisions, and how do we essentially work through that and understand it at a granular level so that we can support them in the best way in each of those decision points. I would love to talk to you about this more because I think it's fundamental.
It really is, and it's fairly simple, but it is four-dimensional, so
yeah.
It's hard to really deal with it all at once. But
yeah.
I went to our hospital administrator when we started PEN, and I said, what one piece of information would you like to see on your computer screen every day? And I thought he was going to give me some, really insightful thing, and he said, I'd like to see the average hospital stay at Duke each day. I thought, good grief. On whom, why, what are you going to do with that anyway? You're fortunate to have Bill, though. Bill is very tuned into this problem. So.
He is. Thank you.
Good. Well, thank you so much for joining us today. Very, very interesting and important work.